But I do think feeling connected to others and other people being kind, as well as other people feeling really comfortable and confident asking you when you're having a rough time, how can I support you? What can I do?
Mhm.
And I mean it. Like I really,
Yeah.
having genuine empathy. Let me check. I'm going to check in on you because I'm really worried about you. Those pieces that I think fall
Mhm.
into the bucket of kindness, I think are absolutely protective factors. Let me
Sometimes it only takes one person to make a difference, and
absolutely.
yeah, that's where you're going. I think,
I
yeah,
would never want to call 988.
yeah,
I would never want to tell anybody. I'm a burden to my family. That connection to your peers who say, I will sit with you all night. I will call 988 with you. I will go to that appointment with you. Or you go, and then you call and you check up afterwards. How did it go? Would you go back? Did you like
yeah,
her?
yeah,
I mean, we have to see it as like as people were full service.
yeah.
Yeah. I'm friends with you during the good times and,
In the bad time,
parties, but, I kind of drop you when you look sad. I think that feeling, that connectedness can be very, very powerful.
Hi, I'm Tony,
And I'm Casey.
and welcome to Anthony's Way, the Road to Kindness YouTube podcast, the way forward, a kindness mission. We want to welcome especially those joining us for the first time. It's great to have you with us. We created Anthony's Way, the Road to Kindness in memory of our dear son, Anthony, with one mission in mind: to help kids with ADHD thrive. Through our expert care and compassionate guidance, we developed a supportive roadmap for parents, one that helps them better understand both ADHD and their child. With our YouTube channel and this podcast, we bring expert voices and practical insights to families so they can navigate the challenges of ADHD with clarity, confidence, and kindness. Before we begin this episode, we want to let you know that we will be covering a very important and difficult topic: suicide prevention, suicide awareness, suicide care. Because September is Suicide Prevention Awareness Month, we feel it's vital to have this conversation. If at any point during this conversation it feels too heavy for you, please take care of yourself. And if you or someone you love is struggling with thoughts of suicide, you are not alone. Help is available. In the United States, you can dial or text 988 to connect with the Suicide Crisis Lifeline right away.
So today we are honored to welcome Dr. Julie Goldstein Grumet.
Hey, Julie.
Hi, Julie.
Thank you for having me.
Julie is the Vice President for Suicide Prevention Strategy at the Education Development Center, where she also directs the Zero Suicide Institute. She's dedicated her career to advancing suicide prevention in health systems across the country, working to make sure that every person at risk is identified, supported, and connected to the care that they need.
We're so excited to have you with us, Julie. Thank you for being here.
Yeah, no, it's an honor to be here with you.
We're grateful to have your expertise and voice in this very important conversation. So, of course, to kick off, we're going to ask you, can you share a little bit about your background and what led you to focus your work on suicide prevention?
Yeah. So I have a PhD in clinical psychology. I, was trained as a clinical psychologist and had actually worked a lot at the time in grad school and after with women who had histories of childhood sexual abuse and trauma. So there's a lot of suicide, unfortunately, in that population. After that was a bit heavy, and I said, maybe I need to step back. And I was working only with adults and said, I think I want to work with kids. So I kind of pivoted and started working in schools. I spent 12 years in schools doing school mental health, which is kind of the idea that the whole school is your client in some ways, and that you need to really do a lot of training in schools, and meanwhile also doing treatment as it arises. But what kept coming up was also more kids still at risk for suicide in schools. And so I kind of kept coming back to it. And around that time, SAMHSA did a lot of investments. SAMHSA is the Substance Abuse Mental Health Services Administration, and they did a lot of investing in the 2000s in suicide prevention. And I really like research, I really like writing, I really like teaching, I really like clinical work. And so running grants in suicide prevention just kind of felt very natural. But I also really like systems change work. And so I did that in schools and now in healthcare. And every time I said, maybe I'm going to step back a little bit from suicide prevention and just do this other thing, unfortunately, I kept finding myself still doing work in suicide prevention. So realized I really have a passion for working to try to change the places where we live and work and learn and hoping to make things better.
Yeah, yeah, that's great. How did you like the school system when you were in the school system? You spent how many years there again?
I was in Baltimore schools and DC schools, Baltimore City and DC
boy.
City for a total of 12 years.
God bless.
I love working in schools. Actually, I just really, I really love it. But there are challenges to working in schools, and things are very siloed. I think definitely the idea of bringing mental health into the schools and recognizing that it's just kind of another subject that has to be as natural as talking about math and lunch and science, I think is something that I feel very comfortable with. And then I also got to do pregnancy prevention with middle school kids and all kinds of other fun topics that I really just like. I really believe in early intervention and talking early about things to hope ensure that kids don't find themselves on the path to greater struggles later.
Right.
I wish more schools felt that way. We're having a very difficult time with the schools here, just even getting our kindness program in, because they read our bio and they see that Anthony died by suicide and they're like, we're not talking about that. And we're like, well, we're not really talking about it either. We just want to look at the positive side and just put kindness, into the school. So there really is, and even the high school that Anthony went to, they didn't want anything. They didn't want to have anything to do with it. No conversations or anything. So,
I remember when I worked in schools, yes, first of all, there's two different audiences that you're trying to tackle, right? One is the schools and the school system to say we have to talk about suicide and suicide prevention.
Right.
It's going to come up, whether you allow us to talk about it and prepare the school and do a comprehensive approach, it will come up. But there's also the parent population. And I know when I would do programming, and it might be anger management or other things, if I wanted to do a suicide prevention program for the parents, I was told, parents might not come, but if you call it, getting your child into college,
right? Then they'll be there.
But then, and it's still wellness, right? It's wellness, self-esteem, and and all of those same skills that you're basically saying you're trying to invest in kids so that they can do well academically and be here and thrive. But suicide, unfortunately, and suicide prevention still holds a heavy stigma that I think people are very, very afraid of talking about out loud. So I really appreciate the opportunity to just talk about it. We can't fix things if we don't talk about it.
No, we do. You're right. And so, a lot of it depends on, we talked to a number of superintendents that head up the school systems, and they know kids are talking about suicide. And some are, it's all done. That one told me that it's all done in batches. Like some years you'll have everybody talking about it, and then another years you won't have anybody talking about it. But some are very open to it and some aren't. And it's a function of, we need to air it, because if you don't, you just can't bury it. It's going to come up.
I think the thing about that, it's so hard to hear you say, oh, some years we do and some years we don't. To me, suicide prevention is really like fire drills.
It is.
Right? It's about preparedness. It's about like, what's our protocol? What's our practice? What are we going to do? How does everybody know their role in a crisis? How are we going to reach out? Who's going to talk to the kid? What's going to happen if a kid goes to a hospital and they come back? How do we manage that? It should be just as natural, because what's our curriculum for science, and what's our planning process? Because I think when you don't do that and then a kid does talk about suicide, that is what makes people feel like they're on fire.
Absolutely.
Because they're not prepared. And I think that's when it becomes even more of a crisis and even more stigmatized. And so I think schools it is in the school. Mental health challenges are in the school. Kids talking about suicide is in the school. And the more the kids feel like, oh, this is a safe place and I know who to talk to, I think that eases and really improves, I think, the safety for their kid, for the other kids, for the faculty who work in the school, not talking about it doesn't make it not happen.
Right. Exactly,
Right.
Exactly.
That is a big misconception though, that I think a lot of people have. Well, if I talk about it, then I'm going to put a thought into their heads, and then they'll have something else to think about. So
we're all big on creating safe places for the kids.
Yeah.
That's what we're about. We want to make sure they feel safe, and then we want to make sure they feel comfortable sharing. And we have to get through these kids that it's okay. So
yeah,
it's great.
And I think, I get calls sometimes because I know sometimes what a school will do is they'll want to check the box off. We did our suicide prevention activity, and they'll have a speaker come in.
Yeah.
Right? The same kind of like, oh, I drove drunk on prom night. Don't be my story. And they do their one-time event. I didn't drive drunk on prom night, just to be clear. Just in case.
Noted.
Thank you. But I have had people call me and say, I've been asked to give a talk, or I'm doing the rounds. And what I always say when those speakers reach out to me is, what is the school's plan besides you? Because doing a one-time event is not a comprehensive, it's not really a great suicide prevention program. It's not a great approach. And what happens when a kid goes up to that speaker at the end and says, thank you for saying this. I have felt this way. That have they told you who they want the kid to reach out to? Does that person know the kid might be reaching out? Does that person have a plan as to how they're going to make a referral or reach out to the parents? They said it should never be, we're just going to drop this into the assembly and then, check off that we've done it this year and then move on for next year. That's not,
doesn't work like that.
No. And it's also not fair to the kids' peers. If they all are sitting and eating lunch and somebody says, well, I feel that way sometimes, the kids need to be prepared. There's all kinds of great programming about how do you make the kids because we know kids tell kids.
They do.
Right. They do.
Great programming available to make kids understand what they should and how they should speak and how they can support their friends.
Yeah, that's right. That's great.
So tell us what the Zero Suicide Initiative is.
Yeah, so Zero Suicide is really about how does a healthcare system recognize and respond to somebody at suicide risk? And by health system, that could be your pediatrician. It could be if you go to the emergency department because you break your leg. It could be an oncologist that you're seeing for breast cancer. It's any door in the healthcare system should be the right door to recognize that somebody's at risk for suicide, whether that's because the individual says, I'm thinking about suicide, but we know people often don't do that because they've had a bad experience when they've done that before. They're afraid they'll get hospitalized, or they've had bad treatment, and so they don't want to talk about it. But we also know that when asked directly, people will share directly. If somebody is asked very directly, are you thinking about suicide? Are things so bad that sometimes you think about killing yourself? Or they take a suicide screening tool, a standardized tool that is just part of the assessment that they take as part of their well visit or while they're waiting in the emergency department, then we know that people often acknowledge thoughts of suicide. So what Zero Suicide is some way somebody's identified in the healthcare system, either by asking or typically more by screener, and then that there's a series of activities that take place to reduce that individual's risk. So there's a set of clinical activities, clinical components. You assess the risk using a risk assessment. How severe is the risk? What kind of treatment would best reduce this person's risk? What kind of care do they need? You initiate a safety plan, which is a set of coping skills that help somebody, how do I reduce my own risk? Because that's what we want, is people to have self-efficacy to manage their risk. You reduce their access to lethal means by ensuring if they're thinking about suicide that they don't have access, and you talk about it directly, just like you take the keys from your friend if they've been drinking too much at the bar. It's just a thing. While you're at increased risk for suicide, we got to take the lethal means away from you, but in a way that we both agree makes sense. And then you make a referral. And you ensure that the individual goes to that referral. So that set of clinical pieces of care is what we want to have happen no matter what door somebody walks in. Pediatrics, emergency room, oncology, psychiatry. We also, though, want the organization itself to be set up in such a way so that everybody's trained, so that if they talk to the nurse, if they talk to the doctor, if they talk to the tech, everybody understands what suicide prevention is, that they feel very comfortable talking to the person. They also have the training to deliver on these evidence-based interventions that we know work, that it's okay to talk about things that they don't know and say to their leadership, I'm not comfortable talking about lethal means reduction or access to lethal means. How do I do that, right? The assumption shouldn't be that anybody who works in a healthcare system because they're licensed must be an expert in suicide prevention, because typically they're not. So Zero Suicide puts that responsibility on the healthcare system leadership and says you have to make sure that everybody is very comfortable and confident and competent to care for people at risk for suicide. And then the other really key piece that differentiates Zero Suicide is using data. Are we doing all these things, all those things that I just walked through really quickly? Are we doing them at every visit? What are we finding? Who's at risk? Are we addressing their risk? Are we reducing their risk? Are we training people? Is it working? Because otherwise you're just kind of throwing a whole lot of stuff out there. But actually, at the end of the day, year after year, you don't really know, are we having an impact?
Right.
So that's really what Zero Suicide is. It's the idea of how does a healthcare system organize itself to both deliver evidence-based treatments at work, but also organize itself as a system to make sure that they are well prepared, comfortable, confident to deliver that care every time, and also that they're measuring the impact of that care and making changes. So if they're not seeking zero, they're not screening at every visit, how are they engaging in activities to do better?
So how far-reaching is Zero Suicide? Is it across the country? Is it adopted by all healthcare locations? Where are we at with it?
Well, that's what we're hoping.
Okay.
That it gets adopted by all healthcare systems. It is not today.
Okay.
We have a ways to go. It's probably been adopted by a couple thousand healthcare systems, so that whether that's a hospital or outpatient facility, community mental health, it's been adopted by a couple thousand easily, but we just launched a registry, actually. There's a National Zero Suicide Registry on our website, which is zerosuicide.edc.org. And so people can see what healthcare systems have so far registered that they're doing zero suicide. But the other thing I think that's really important to think about is zero suicide isn't sort of a binary, we are doing it and we're done. It's our thing for the year, and then we move on and do something else next year. It is a continuous investment in improving how you do work. So it is something that healthcare systems will have to keep reinvesting, and I don't mean financially, but I mean sort of their energy and their attention to, so that number just keeps going up and up. And we're doing what we can to really bring it into healthcare. It's both national, but there's also tremendous zero suicide work happening in Canada, Australia, the UK. So it's really been this idea of a comprehensive approach to suicide care has really, it's what works. It's what the literature says works. And so it really has been well adopted.
So how do you know how do you track this? How do you measure to say that, is it the new questions that now we're being asked? Like, there's questions now every time you go in, you check the box. Yeah, I know. But so, but how do you know everybody's following through on what they said they would do?
You mean, how would you, as a patient, how would you know that if... How do you know it's being... How would I know as the lead?
How is it being measured? If you track this, how do you know?
So a few different things. I think one good sign, and I think we're seeing pretty good penetration to this, that if you go to your annual well visit and you take, it's often what's used pretty commonly is called the PHQ-9, the Patient Health Questionnaire, 9 items. And, the last item is, do you ever feel like you want to go to sleep and never wake up? So it's not the best. It's really more of a depression screener, actually, because that's not really the best way to ask people about thoughts of suicide. But people will often use that as kind of a rule out of, oh, okay, if you say no, we're going to assume you're not at risk for suicide. But I think it's an important thing to kind of habituate people to normalize the idea that these are questions you'll be asked when you go in for your appointments.
Right.
Because the other thing is we want that to be done at every visit so that it's not, you might not be at risk today, but something might happen in 6 months.
Sure.
Yeah.
And we want you to be asked then as well. And we want so that's one way that you would know that zero suicide, or at least an investment in thinking about your mental health, has been addressed. I think it's hard to know because the idea of how do we know what the penetration is? I mean, our suicide rates in this country are still going up.
Yeah.
There was kind of a blip where it went down a little bit a few years ago, but it just continues to rise over the last 20, 25 years. So there are pockets where it's going down, and I think it's why we have to do this continuous quality improvement, and healthcare systems need to measure the impact and then report on that and write journal articles so that we can hold them up as gold standards to say, this is how you make change happen. This is patients getting better.
Yeah.
So I just want to confirm what I think you said. The people that are filling out the questionnaire, you think they're being honest on the questionnaire? I mean, you really think that they're, because if they're sad, they're like, I mean, I fill it out honestly, but I can see somebody saying, well, I don't want somebody to contact me, about being sad or whatever. So do you think that they're being pretty truthful when they answer those questionnaires?
The research is mixed. I mean, the research basically says one way that we can identify people at risk is by using screening tools, and that some people, some of the time, will answer honestly. And so we need to use that as one means that we have at our disposal. But yes, they have found people who have died by suicide who answered, nope, not thinking about suicide on some of those questionnaires, which means we have to think about other ways too to ask.
Yeah.
It means also, though, how do we, whether it's a physician, or a psychologist or somebody else in your healthcare treatment who just says, I don't know, you're telling me about a whole lot of things going on, or you're really been in here 4 times this month complaining about stomach aches or something you just told me about, or nothing. It doesn't have to be some major trauma. But so we also need people to be kind of tuned in to some of those other signs and ask. And then I think in our community, by our loved ones, right? Screening tools are good, but if we're only at a healthcare visit, once a year or a couple times a year, it's not enough.
Right.
So we need to think about our faith community and our family and our neighbors and our schools, and really, again, making this conversation of, gosh, you've really had so much going on. I'm a little bit concerned about you. How are things going? Or taking that conversation further. Are things ever so bad that you're actually thinking about killing yourself sometimes? And those, I think, are really, they're not the things, you don't get taught how to have those conversations.
Right.
But I think the more we do it, the more we make people feel like it's okay to talk about. And then how we do it really matters, right? I think if we say to somebody, we're not making eye contact, or we say, well, you would never do anything stupid, would you? Right. And I understand why people say that, right? Both be their own anxiety or it is their judgment. I mean, they are being judgy. And if that's the way it's received by the person who's being asked that question, they might think either you can't handle my answer, or you are judging me, or it absolutely doesn't feel stupid to me. If you were in my shoes, you wouldn't think it's stupid either. Right. So we really have to be very mindful that somebody's in pain, and we need to ask them very directly without adding all of those layers of judgment or oh, your life will get better, don't you worry, I was 16, you'll have so many other boyfriends, don't you worry about that.
Brushing things off and the connection's so important. I mean, the doctors are busy, if they take the time, hopefully they do take the time and they do identify, or they can identify. But the program's great as long as everybody does their share, right? And the neighbors too. Like, we live in a community. If you don't see a neighbor in a while, you start asking, where's the neighbor? Like, what's going on? Is everybody okay? But it's all about connection. It really is, and listening. People need to listen more and just take the time to care about people.
Yeah.
And I think that pushes that.
Well, and what's fascinating is a lot of these school-based programs, I think historically were built on like, well, we'll train up the school counselor, right? Because everybody will
Yeah.
tell the counselor, but actually what they teach is who are the natural gatekeepers is the term they use. Who are the natural gatekeepers in a school, right? Maybe it's the coach, maybe it's the janitor, maybe it's the lunch lady, maybe it's the English teacher. Like everybody loves Miss Smith.
Yeah.
And would tell Miss Smith all their problems. So if you know who those, 4, 6, 8 people are in the school that just kind of everybody talks to and has their finger on the pulse, then you train them.
That's
like,
right.
It doesn't have to be like Dr. Smith,
Right.
Dr. Jones, right? Because maybe that, I mean, or in addition, it should probably be Dr. Jones. But use those people that are naturally in your school or in your community that everybody talks to, but make sure they have the skills to have these conversations and then have a plan. Not, well, you just stop by my house every Monday and we'll chat, but something like, okay, let's call 988 together, or let's, do you want me to go to that first appointment with you? How can I help you?
Yeah. Plus, it ripples through to your faith. You said the faith organization earlier. It does ripple through the faith organization. So important. I mean, they need to listen too. They need to be able to pick up on this stuff too. If someone's not, these youth groups are so important. And we go and do kindness programs with the youth groups, and you could really pick out who's really into it, who's really working it, or who's just there. Some people are just there. I mean, because they have to be there. Even some of the youth counselors. So it's a function of really getting the right people in the right roles. But I like where you're going with the gatekeeper approach, because that everybody will talk to someone, right? You would hope so.
Well, so with Anthony, he was getting ready to go to college. He was in an emotional relationship that he wasn't ready for. There were no signs for us. I'm going to say there were no signs for us. Because he was an 18-year-old in a relationship. They were having some difficulties. We were trying to let him take care of some things on his own because he was getting ready to go to college. I can't follow him to college, and so I was just trying to help him, learn how to mature a little bit. And then unexpectedly, because of his impulsiveness, he died. So are there any warning signs that some general ones that maybe you can talk about that maybe parents of high school students or even younger students maybe that they could look out for? Because we didn't notice like any depression or sadness or weight loss or giving away things or any of that stuff. So
we had no guns or no lethal weapons.
We had nothing
in
in the house.
Those things we never kept around. So
yeah, and I'm so sorry for your loss. And I think unfortunately, I do think it can be hard sometimes to see those warning signs. Either kids do a good job of hiding them, or they come on so fast. I mean, a kid can cycle through those feelings in minutes.
That's what happened.
And if they do, and they have the means, or they have a plan and they're able to execute that plan, then unfortunately, they could find themselves in the position that you're in. I think, so it's not, and we also know that half the people who die by suicide don't have a mental health diagnosis at the time of their death. So it's not, if you die by suicide, you definitely were depressed or anxious, or, as I said, and we know that kids' brains aren't fully developed. We know that those feelings can come on like a ton of bricks out of nowhere. We know that it, coupled with the impulsivity, coupled with access to lethal means, can be very dangerous.
Yeah.
I do think, one of the ways, so what do you do? Right? I mean, I do think that some of the things are, how do you talk about mental health? How do you talk about knowing if your kid is impulsive? How do you bring these conversations in to make them very natural as early as possible? So those things that you may not be able to plan for every contingency, but how might you talk about, what would you do if you found yourself feeling really down or sad? What would you do if you found yourself having a really bad day? Who would you talk to?
Yeah.
Who do you know that 988 exists? 988 is the nation's crisis line. It's 24/7. You can call it, you can text. People are available all the time. Would you call that? What would get in the way of you calling that if you were just having, if you were having a really horrible time and you were actually thinking about suicide? Would you call that number? Why not? And then having these conversations that say, do you know anybody who's maybe ever talked to a counselor? What do you think of that? Is that something you could ever imagine yourself doing? Why? Why not? Right? And I don't mean, I mean this, how do you have that become because you're watching a movie, because you're watching a television show, over dinner, because you find out that your neighbor is broke up with somebody and they're really upset? Like, how do you just integrate these conversations into your everyday life so that it feels natural?
Right.
Just like you do all these other conversations about, raising teenagers. Like, my kids are exhausted by me being like, let's talk about safe sex. Right. I have teenagers in my house. They're not sexually active, but I'm not waiting.
Right.
So they are, to be like, okay, let's have that conversation. I mean, I had that conversation once with my son. I think he was like 12 or 13, because I just wanted to talk about safe sex. And he literally goes, Mom. 12.
Like, yeah. Oh, yeah.
Well, unfortunately, that's not too early.
No, it's not. But yeah, still. Yeah, we've had those moments where with our girls and with Anthony too. So yeah.
Yeah. So I like that, making it a part of the conversation. Suicide was never on our radar. Mm-hmm. We never even thought to talk to Anthony about suicide, or what would you do, or whatever. We knew that he was impulsive and we knew that he could get emotional, but we never ever dreamed that anything like this would happen. So I do like that, making it part of the conversation. And as a parent, just making it part of the conversation, like you just said. I think you had some very wonderful tips on how to have that conversation. So thank you for that.
Yeah. So how about sharing some success stories, Julie, where zero suicide model has really made a difference, where it's made a difference, you could see it?
Yeah, I mean, I think, a few different things come to mind. Data collection is critical. If you're going to try to change your system to do better with identifying people and caring for people at risk for suicide, then, as I said, you have to measure data to say, are we doing what we think we're doing, and is it working? Mm-hmm. And we do know, we've worked with healthcare systems who have reduced their rates of suicide in their population by even 65-75%.
Wow. That's great.
We've seen healthcare systems who have been able to reduce people being admitted to the hospital because they're providing better care in outpatient systems. So they're able to reduce their risk and not have to rely. There's something, I mean, if somebody needs inpatient care, then absolutely they should go. But we don't want people can't live in inpatient psychiatric hospitals. So we want them to live in the community. We want them to get good care in community mental health. We've seen examples, one of my colleagues who leads a healthcare system talked about one of the pieces within zero suicide is, again, it's really the organization taking responsibility for somebody as at risk. So if you come to see us and we've done a screener and we've determined that you're at higher risk for suicide, then we basically put you on what we would call the suicide care pathway or suicide care management plan, meaning that for some period of time while you're at higher risk for suicide, we're going to kind of throw everything we have at you. We're going to check your safety plan every time you come to visit. We're going to talk about lethal means safety. We're going to do treatment that we know works. We're going to use, there are lots of evidence-based treatments that reduce the actual thoughts of suicide and suicide behaviors. We're going to do that. And if you don't show up for an appointment, we're going to come and find you. We're going to use your emergency contact list. And it's not meant to be a scary thing. It's meant to be you're at higher risk, and we're going to do what we can do to keep you safe. And that includes if you had a 9 a.m. appointment and you don't show up, well, we're just not going to leave a message on your voicemail. We're going to actively, and we've talked about it when we put you on the high risk pathway, right? It's meant to be very, it's collaborative. This is what, just like, oncology treatment, cancer, this is what you get, and this is what we do, and this is what we expect of you. Well, so we know that one of our systems that the employee Zero Suicide had somebody didn't show up an appointment, their crisis line reached out, hey, where are you? And he was standing on a bridge.
Oh boy.
But he got that call.
Wow.
We're able to talk him off the bridge and to come into treatment. And he's okay.
Yeah.
And that is because the healthcare system said, we are going to own our part in your safety.
Sure.
Right? We have to all do our work, but we are going to own our part, which is we understand that sometimes when you're under this much distress, that impulsivity, those thoughts emerge really fast. You may even think about doing things to kill yourself, but we're going to do what we can if we know that you're at increased risk to keep you safe. And there are a lot of examples of those kinds of saves as well.
That's great. Very good. Go ahead.
What have you seen change in the landscape of suicide prevention over the last decade, and what still needs urgent attention?
Yeah, one of the things, so last year in 2024, the nation released an updated national strategy for suicide prevention. So the first national strategy was produced in 2002, then it was updated in 2012, and now the most recent one was released in 2024. And with each of those national strategies, the first one in 2002 was very much awareness. It was a lot of the strategy in that was, let's build awareness that we can do more. Let's build awareness about suicide. Let's talk about it directly. In 2012, a lot of research in the 2000s had really emerged about evidence-based interventions. So these things like safety planning and lethal means safety and treatments that directly target thoughts of suicide. A lot of those treatments had really, those interventions had come out with a lot of research. So the 2012 national strategy talked a lot about using the evidence base, not kind of just anybody do anything and hope it does something, but rather use evidence-based interventions. 2024's national strategy really focuses a lot on what is the impact and is it working?
That's great.
And I think that's really important, is that we have a lot of interventions. Have more people involved in suicide prevention today than ever before. We have treatments that work, but now we really need to know, with the numbers going up, are these things working? If so, how? With whom? Not everything is going to work in every population, every age group, every demographic. So we need to be really smart about that. And understand more and do the research and be very clear, and measure all, so that we can there's limited resources. So we need to really focus our resources and ensure that we're doing what works. So that's a huge change. I think the other change that a space that we really need to go is, I think you were saying that there are a couple of states that have now required teacher training.
Right. Yeah, 21. Yeah.
And that's amazing. But we also know that in suicide prevention, a lot of licensed clinicians really have very little training in suicide prevention. When I finished grad school, 30 years ago.
You don't have to say it.
Yeah, no. 12 years ago, there was no training in suicide-specific interventions, and as part of licensure or continuing educations, for most, it still isn't required. So that's, I think, another big change that we just really, it's emerging, I think, more and more, but I think it's a space that we really need to keep doing.
So do you think all the COVID stuff had an impact too on raising the suicide rates? I mean, that's at least what we've heard. Haven't seen the stats on it, but we've heard that it has.
Well, we saw that actually suicide rates went down for a little while
Yeah.
during COVID, right? That idea of like we're all in it together, and
Right.
so for a little while it went down. There were certain segments in the population, girls had more emergency room visits than previously, but we were kind of having a youth mental health crisis before COVID
Mhm.
started. What I think COVID really did was help unpack that mental health is a challenge for kids in school, kids in general, and
Mhm.
that we need to pay a lot more attention to it. So I do feel like people are much more willing to talk about mental health now than they
Yeah.
were prior to COVID. I think of all those articles, right? Physicians and caring for people during COVID and what it did and the distance we had from each other and kids being out of school. I think there's a lot of research about some of the damage that happened as a result.
Right.
And but I think people in general are far more willing to talk about mental health now. I mean, you asked,
Okay.
what else has changed? I think was your question in the last 10 years. I mean, AI and technology, social media. I mean, it's not all bad. There are things about it that I don't love and would be happy to have a lot less of it in my house. But access to, I think AI and some technology, I think is going to, the wearables that can track your heart rate so that you have better ideas of, what's my emotion, happening today. So somebody else is monitoring that and can intervene. We can track conversations that are happening digitally and do a lot of training of, how was that intervention and how did that work for patients? I mean, I think the use of AI in real time to figure out who might be at risk and how do we use interventions immediately, I think is really something we're just beginning to, to peel the onion back about.
That's great.
So we're having a challenge with our mental health system right now. There's not, that's what we're hearing, at least with the ADHD kids. There's not enough psychiatrists to go around. There's not enough psychologists to go around. Yep. Is that something that, are you aware of anything that's being worked on about that?
Yeah, I mean, I think technology is one of the things that happened during COVID actually is the greater access to telehealth.
Right.
Yeah. Prior to that, it was really hard, and licensure really kept people limited to the states that they operated in. But some of those silos have been reduced.
Okay.
So I think having greater access to telehealth is one space that is going to help. I think some of the emergence of technology that may be self-paced, I don't think we should not be using AI at this point for treatment. Right? We don't want to use ChatGPT for treatment. There's a lot in the media about some really horrible.
That shouldn't become your best friend.
No, it should not. But I do think that there are ways, but we are learning more. And I think over the next few years, we'll learn more and more. And I think that, not everybody necessarily needs intensive treatment either. And so I do think some of these things will become, when we can harness them and use them safely, I do think that there are ways that we can expand the reach of our limited mental health system into really high quality tools that people might be able to use at home. And then, we were talking about the faith community. For some people, they'll do really well talking to other kinds of community leaders or people in their schools.
That's important.
But I think, it depends in some ways on what it is that people are struggling with. But I think in a lot of ways, we all have to be available to support people around us in distress. There's a line at which, we're not all licensed clinicians and we can't do evidence-based treatments, but we can certainly help reduce people's distress and be there and be supportive and hopefully not get them further down the continuum to the point of crisis.
So one of the things we run into is that we work in a lot of states, and we have psychiatrists that are in certain states, but they can't work in the other states that maybe the issue or the challenge might be in. Do you see some of that changing over time? I see some of it being relaxed a little bit, but I mean, unless they get licensed in the states, they really can't help. And because we had one family that came to us and said they would like a redo of the child's medication. And we said, well, we could do that here, but they wanted to go to the experts, and the experts weren't. Now they can go travel to that city and go visit that doctor, and that would be okay, but not doing a telehealth call and talking
And
with.
for many, that's expensive, and
Yeah,
I mean, and they
absolutely. So
right?
we have to do something to help. Yeah,
It can't be the bar that we're
right.
everybody to. I think that there's more and more reciprocity around licensure. So I do think that we will, as I said, I think COVID really shook some of that loose. I think there will be more and more. And I think, especially because the research says, I'm not sure about with medication, I'll be honest, but I think the research, and certainly in the treatment world, is that people did just as well in virtual online treatment as they did face-to-face.
Right.
Because in some ways it did reduce those barriers of I have 3 kids at home, I couldn't find a babysitter, so I'm missing fewer appointments, I can fit it into my day, or I'm more comfortable in my house. So I do think that I think we'll see more and more of that. There are some really good technology companies coming online that are providing, like there's one that focuses on eating disorders. There is one that focuses mostly on suicide care. And I think there's more and more of those kind of specialty technology-based virtual treatment companies coming online.
That's great.
I think as long as they're tracking their results and, ensuring that the care is evidence-based, high quality, I think some of those walls will get broken down.
Great. It's good.
Yeah, this might be a dumb question, but is there a leading cause of suicide? Say like for teens and young adults, is there been a leading cause determined? Is that a dumb question?
No, I don't think it's a dumb question. I mean, I don't think I know the answer to that.
Okay.
I think suicide is so complex.
Yeah.
People can live with thoughts of suicide year after year after year. I mean, 13 million people are walking around having thoughts of suicide. That's what the kind of national surveys say, 13 million.
13 million people.
Right.
About suicide, but only about 49,000 people die by suicide. Now that, I don't want to say only, because that number is way too high, but that means people manage or do something to manage those thoughts of suicide. So I think for people, there isn't one singular factor typically that makes somebody, it's a constellation of things, and it's sort of your temperament, your makeup, access to lethal means is huge. If you are living with somebody who is struggling with thoughts of suicide, has talked about suicide, one of the absolute first things you need to do is remove access to lethal means. And guns are really one of the number one ways somebody can die by suicide. So when you ask, what is the number one thing? It's get rid of the gun. It doesn't have to be forever, but if you know somebody's at risk, then move that gun out of the house, use a gun lockbox, do something to remove access, because if somebody's thinking about suicide and they have access, then their risk has gone up exponentially.
Yeah. So how about, we're obviously big on kindness, Anthony's Way to Road to Kindness. Is there a role, or do you see the role and connection with being kind and the community awareness and playing a role in prevention?
Yeah, I mean, I don't think it's the only answer, right? People have mental health challenges, or you can be kind and still have something happen where your impulsivity and your thoughts go up really fast. Right. But I do think we do know that feeling of being connected to others is a strong protective factor.
Yeah.
And so I do think having, whether it's both to your peers, to your faith community, having a meaningful person that you can talk to is an incredibly important protective factor. Having a sense of responsibility, caring for a pet, caring for a parent, caring for a sibling, those are very important protective factors. And that sense of self-efficacy, that sense of I matter, right? All of that can be extremely protective. So people shouldn't be so afraid to say, gosh, I really appreciate what you did for me.
Right.
I think feeling, it's not a straight line. If you feel connected, you won't think about suicide, right? I don't think we have research to say, unfortunately, something like that. But I do think feeling connected to others and other people being kind, as well as other people feeling really comfortable and confident asking you when you're having a rough time, how can I support you? What can I do? And I mean it. Like I really, having genuine empathy. I'm going to check in on you because I'm really worried about you. Those pieces that I think fall into the bucket of kindness, I think are absolutely protective factors.
Sometimes it only takes one person to make a difference, and that's where you're going, I think.
I would never want to call 988. I would never want to tell anybody I'm a burden to my family. That connection to your peers who say, I will sit with you all night. I will call 988 with you. I will go to that appointment with you. Or you go, and then you call and you check up afterwards. How did it go? Would you go back? Did you I mean, we have to see it as people were full service. I'm friends with you during the good times and during the bad parties, but I kind of drop you when you look sad. I think that feeling, that connectedness can be very, very powerful.
So how about any other messages of hope that you could share with the listeners today? I mean, what you're doing is tremendous, and where you're going, and we hope that more and more hospitals and healthcare organizations really get tied into the protocol, because it does work. We believe it works. And any other messages of hope that you'd like to share?
I mean, I think I'll share two. One is just about zero suicide, which is I'm going to share the website again. It's zerosuicide.edc.org. That website is a toolkit. It's really meant for healthcare systems to use as a toolkit for how do they get started. I run the Zero Suicide Institute. We do provide training and consultation if healthcare systems are interested in getting training, because sometimes they say, boy, this is a big undertaking. It would be helpful. So, I certainly encourage healthcare systems, if they're thinking or listening to this, to think, what is your data telling you? How well are we doing? If I were to ask 10 of my staff, do you feel comfortable and prepared and confident, to treat somebody at risk for suicide? Do you really know what a safety plan is, or how to talk to somebody about lethal means safety? Do you? And we have a lot of surveys that they can distribute to their staff to actually get true numbers on that. And I'll tell you, most healthcare providers don't feel all that comfortable. So as a healthcare leader, I think it's your responsibility to know that and do better. As somebody seeking healthcare services, I think it's okay to ask. I think in the medical side, people talk about get three, a couple of opinions, right? You've just been diagnosed with prostate cancer. When my husband was a few years ago, everybody encouraged us to meet with 2 or 3 different who was going to give them the best treatment, and nobody balked. Like, that would be weird to shop around.
Right.
I think the same thing should be true in mental health and suicide care. If you're having thoughts of suicide, or your loved one or your child, ask, what do you do? How do you know that your treatment works? What should I expect? Tell me what treatment would be like. It shouldn't be some kind of a mystery. They should have a plan. Just like when my husband, as I said, had prostate cancer, they told us, we will do this, and then he'll have this surgery, and then the recovery is this. This is, how many years, this how many hours the surgery is, right?
Yeah.
There are treatments. I've walked through the treatments now a couple of times, today. There are treatments that work. If you meet with somebody, they should be able to tell you, I use those treatments and I understand, and this is how I believe that they can work for you, because there's no reason we can't interview our providers and understand. And your provider should offer you hope. Any provider that you meet with should make you feel like they have the skills and the compassion that you would want to go back and meet with them and be a team and tackle these thoughts together. And I think that's what, my message of hope is that there are treatments that work. People can and do get better, and they thrive. You have to kind of stick with treatment, a lot of the time, find a provider that works for you, but lots of people have thoughts of suicide and they get better. and they find meaning and they use treatments and they do get better. Most of those thoughts don't last. In my house, I talk to my kids a lot about, is this a 10 out of 10, right? With 10 being like unbearable. Is this a 5 out of 10? Is this a 1 out of 10? I think, ask yourself, right? If you were just having a horrible day or you're having thoughts of suicide, I think for most of the time, it's that 10 out of 10 time is that scary time, because that's when that impulsivity or that, I can't think of any other options, but kind of takes over. But we know that 10 out of 10 space just doesn't last.
Right.
So just remember that. And
it's great.
Really
great points. Well, we're definitely going to put all your information down below in our captions, so everybody will know where to contact you, so they can reach out to you. The one thing that we have worked really hard on, Julie, is we didn't know that ADHD life coaches even existed 20 years ago, or and so we always ask the question, because you've mentioned it a number of times, and we have too. The impulsivity, we have to figure out how to get kids and everyone to pause and just take a step back and say, okay,
just give it a minute.
Give it a minute, breathe, whatever the techniques are that we want to deploy. But it's such a challenge with these kids that have ADHD that is the biggest thing we see, is their impulsiveness is just over the top. And it was, for Anthony, it was one that we couldn't get our hands around, and he couldn't either. And as much as we tried to get him to back up, but we these coaches that we're working with, they have told us, and I believe they have the ability to help to get kids and even adults to just pause, just to take a step back and breathe. And it's so important. I mean, what you're doing is tremendous, and we value your time today with us. And is there anything else you'd like to add before we conclude?
No, I think the work that you all are doing, in your son's memory and honor is really so special and important and invaluable to other parents. So thank you for doing this. And
we appreciate it. We're on a mission, just like you are.
We're all together.
We have to be connected.
We're trying to work together to make this world a better place.
Yeah. And so every little piece counts. If we can put them all together, connect the dots, we'll get a lot farther along. So. Okay, Casey likes to, so she closes with some.
Actually, I'm going to switch it up. I think I'm going to switch it up this time. Yeah.
Go ahead.
Because I found something else that I think I would rather say. So again, thank you for joining us today. Conversations like this remind us that suicide prevention isn't just about crisis moments. It's about creating systems, communities, and connections that help people stay safe and supported every step of the way. At Anthony's Way, the Road to Kindness, our mission is to spread kindness, raise awareness about ADHD, and help kids and families get the early expert support that they need to thrive. During Suicide Awareness Month and every month, we encourage you to check in with the people in your life, the people that you love, listen with compassion, and remind them that they are not alone. If you or someone you love is struggling, please remember that help is available 24/7 through the 988 Suicide and Crisis Lifeline. Thank you for listening and for being a part of this movement of hope and kindness. That's it. Sorry, that was the end of it.
Yeah. I mean, it's important. Hope and kindness are so important. So we like to always close with our motto, and we have this thing that life is better with you. Mm-hmm. And we believe that it's so important that these kids and everyone understand life is better with them in it. And we need to tell them that message. And we have our family motto that we shared with, and we hope thousands and millions of people will put this on. Today is the best day of your life, and tomorrow will be even better. And we want folks to put it on their fridge, put it on their and so this is one thing that we share, is that Anthony was, every morning he'd be running out the house to catch the bus or whatever, and he'd be yelling down the stairs to me, "Dad, today's the best day of your life. Tomorrow's going to be even better."
Nobody was yelling it.
Yeah. We were both yelling it. So
yeah.
But it was just, that's the special stuff, and that was the thing that keeps us moving. So thank you everybody for listening to us, and thank you, Julie, again for your words of wisdom and your insights. We really value your time and your efforts. Subscribe, listen to our channel. We hope you join us all the time, and thanks so much, everybody.
Take care.
Take care.